All right, go right ahead.
All right, my name is Michael Remetz. I'm an interventional cardiologist. My name is not Linda. Unfortunately, my wife has contaminated my computer. It includes my Google. So I guess that's good these days because you can't tell where I am at any given moment. It could be me or my wife. But anyway, we're here today to review a basic lecture, and we're going to cover the topic of femoral access. I've been doing interventional cases for pretty close to 35 years, so I've seen a lot of stuff come and go, and I'll try to enhance this talk with that type of information. I have no conflicts to declare. I'm not getting any royalties or anything from any particular device, catheter, or whatever. As I said, we're going to review femoral vascular access and complications. Karthik, I understand you have a different lecture for radial access, correct?
Yeah, that's right.
Yep. Yeah. Okay. So we're going to specifically focus on femoral. So I just wanted, beginning in the year, we should talk about just some very basic stuff. And this is, it may seem simple, but I've seen a number of times over the years where fellows get in trouble because they do something ridiculous with a sharp. It's a very important thing, and the techs, especially in the cath lab, are always trying to keep track of the sharps, and you're a big component of that. So there definitely can be, I mean, we've all gotten stabbed once or twice too. So we want to try to keep these things to a minimum. So we have over on the left-hand side of the screen, that's our standard friend. That's where we keep all our used sharps, that little red box with the needles jabbed into the foam. That's a really nice, safe way to keep the sharps in the lab. And all the fellows get into that habit of putting the sharps there. There are specific sharp containers in every lab that need to have that thrown into it. Usually fellows and attendings don't get involved in that aspect, but we really should realize that that's where they go. They get thrown in there, and there's basic stuff that comes up on tests. You never want to stick your hand into a sharp container. Seems kind of common sense, but that's why they make tests, to test common sense things. So proper sharp safety and etiquette, operator's responsibility to account for the sharps, properly dispose of all sharps in approved containers, resheath all scalpels immediately after use and set aside with other sharps. Never recap needles. You will always impale it in that little red box kit you saw. And certainly when you are holding a sharp, you want to make really careful movements, both with your non-sharp hand and also just with your body in general. You don't want to make any rapid turns and spin around. It's, again, seems common sense, but every couple of years we see somebody do something ridiculous and stab somebody. So just keep this in mind. This is a very important thing because as fellows, you'll be drawing up medications. We use a lot of intracoronary or intra-arterial medications, and the dull red needles are the way to go about that. So these are specially designed needles to draw up medications from vials with the nurse. The nurse will talk you through this. We really want to never use a sharp when you're sticking a vial from the nurses. By the way, if there are any questions, just interrupt. I want to keep this an informal session. So when we're talking about femoral access, we want to do a couple very important things. We're going to talk about pulse exam and preparatory work. We'll talk about landmark assessment, and then we'll specifically talk about the micropuncture technique, which is the technique that we've come to use over the last 20 years or so. The access, we want to look at the femoral pulse. We want to access the side with the stronger pulse. if there's evidence of arterial atherosclerosis, there's a bruit or thrill or something going on there, you certainly would avoid that side. And if all of the things are equal, if the patient has distal lower extremity disease and decreased pulses on one side more than the other, you would pick the better side. Again, common sense, but this type of stuff comes up on board exams and such, especially the interventional exams. These are the landmarks. The area that we want to access is the common femoral artery, and right under the inguinal ligament. So in that diagram on the left, you see this is the inguinal ligament, femoral bony head. This is the pelvis, and there's a brim of the pelvis right here that is very relatively superficial, and that serves as your compression area. You see in the lateral view here, the compression in that area is relatively easy. If you get upstream of that, there's a couple bad things that happen. First of all, the artery dives posterior in the pelvis. That's the common and external iliac. It dives down, and it's virtually impossible to compress it adequately. Similarly, if you go distally down the femoral artery into the bifurcation, you get into all this soft tissue. And again, very hard to compress adequately. So your target zone becomes a relatively limited area right around the femoral head and right around the pelvic brim. Just the anatomy again, you have your external iliac artery coming down, and the inguinal ligament divides it to the common femoral, and then you have your femoral bifurcation with the profunda and the superficial femoral artery. So these areas can all be identified both by angiography, ultrasound, and by anatomic landmarks. So, you know, it's relatively easy in thin people to do this. You can almost make out the entire femoral artery by palpation in a thin person. Unfortunately, with our obesity epidemic in the United States and these patients being high risk for cardiovascular disease, this is what you frequently see, where you have a pannus, you have several folds that are evident, and you really, just looking at the surface structures, I've been led astray multiple times by where you are in the femoral anatomy. So you have to switch gears and not assess things by what you see on the surface of the patient, but you have to go more radiologically. And we always look at our femoral head, the bony structures, before we go in to obtain femoral access. So here are the landmarks by quick fluoroscopic exam. You have the pubic tubercle, you have the anterior superior iliac spine. That by definition defines the inguinal ligament. That defines near where you want to have arterial access. The area in here, in the lower third of that femoral artery head, is usually where we try to go. This is on that pelvic brim that we were talking about, easily compressible, relatively superficial, and a good place. This is the place for access. You want to avoid down in this area, the bifurcation area. You certainly don't want to go high up in this area. If you divide the femoral head into thirds, we're aiming for that point. That's a perfect point. It's not too high, not too low. You can't say 100% because there are some patients with a very high bifurcation. You might try to get up in here, but the precision is extremely important, and it's the first step to having a case where you don't have any bleeding complications. So you're aiming for this area. Usually we kind of accept things within that lower two-third of the femoral head. If your needle stick is getting up into this area, certainly up in here, you would want to abandon that stick. This is the micro-puncture kit, or a variant thereof. I don't know if we still have this Cook kit, but it's the general idea is still the same, where you have a 21 gauge needle. Sometimes these needles can be requested with ultrasound visible points. You have an 018 wire, and you have a 5 French catheter that inserts, and it has an inner sheath that can be removed, and an 035 wire can be inserted up there. So we'll go through the steps of working through this kit. This is another view of the kit, a different kit. We've had all of these kits over the years. This is the needle. The needle, as we said, 21 gauge. It is that little black spot is the bevel. All right, that identifies the bevel of the needle, and you always want to have the bevel pointing up. So if you keep that black arrow oriented in an upward direction, you'll have a good access to the artery. You'll have the needle in the proper configuration. And the reason for that is to properly insert that wire going down along the axis of the artery. And then this is the 5 French or 4, this one's a 4 French sheath, which has the inner dilator. And that is how we introduce our 3-5 guide wire. Any questions? Another view of the kit. And this is, we're just going to go through step-by-step pictures of one of our prior interventional fellows putting in a arterial sheath with perfect technique. So she is using the hemostat to establish a radiographic fluoroscopic position. You can see that the tip of that hemostat is near the lower third of the femoral head, and that is the area that she wants to insert the needle. And you have to be conscious of the fact that the needle is on an angle. So if the patient is big, you're going to have a significant change in the level of that needle as you go in on an angle. So you have to account for that. And again, entry into the artery right at that lower third intersection on the femoral head. This is where we have established the needle access. So she goes in and inserts in the artery, and you'll get that flash of bright red blood back through the needle. And the 018 wire is inserted very gently into the artery and advanced up the iliac system. Once we do that, these are habits that have been developed over the years, but we always fluoro that area. You fluoro the needle and you fluoro the wire. You want to make sure that the needle is in the proper position with relation to the femoral head. You want to make sure that the wire is in a good area that makes sense with arterial access. It's not going up into the other areas that don't follow the iliac artery system. So this looks good. The needle tip is about at halfway on the femoral head. And if you're getting up into this area or above the femoral head or even high on the femoral head, it's perfectly respectable to abandon the approach. Better to abandon things with an 18 gauge needle that's very tiny versus putting in the larger sheaths. You're going to have more problems with bleeding if you put in the larger sheaths. So this is the time to perfect your location of the access. And it's not often that it happens, but sometimes we will make the decision to abandon because we're up in the high areas, or if we're particularly low, you might abandon that site, hold a few minutes of pressure, and then retry again to get a better position. This is now that dilator has been removed and an 035 wire has been inserted, and the operator is inserting the larger sheath over the 35J wire. And that's, we'll go over that sheath, but there's a dilator that helps you facilitate entry into the artery. There's the sheath itself, and there's the wire. So I wanted to spend a little time going over wires. This is our Workhorse wire, the 0.035 inch diameter J-tipped wire. It's a very forgiving atraumatic wire. It generally follows vessels. It's got good visibility. It's flexible. The downsides are that you cannot steer this wire. It is, if you are going into a certain area that you don't want to go into, or you can't pass an obstruction, this wire is usually not too helpful. It will, always tend to go to the same place, and it's difficult to get that tip to move around. You need other types of equipment if you run into that difficulty. This is just to show the components of an arterial sheath. Sheaths are described in French size. 1 French equals 1/3 of a millimeter. Most of our sheaths that we use for routine cases are 5 or 6 French sheaths. That again refers to the outer diameter of the sheath itself. They're also color coded. The 6 French sheath is green, and they have a side port. Very important. It's over the years, it's been established as good technique to when that sheath is not in use and a catheter is withdrawn, it's always the fellow's job to flush the sheath. So you would aspirate back, clear the sheath of any clot or untoward contents, and then flush through with clean, no bubble saline to clear that sheath to make sure the thrombus doesn't form inside of it. That same side port can be hooked up to pressure and can be used to monitor pressure. You have the dilator that is used to access the artery. Always make sure that the dilator is in proper position in the sheath when you're going into the artery. Sometimes they slip apart, and that can be a problem because if you try to just insert the sheath without the dilator, you usually get hung up on the artery. It's usually not a big deal, but sometimes it could ruin the sheath, or worse yet, it rarely can ruin the artery. So you want to make sure that all the equipment is hooked up and established correctly before you go in. Then you have that central lumen where you use where the wire goes through, and that's how the sheath is fed over the wire. It also has a hemostatic valve in here, so when you remove this dilator and wire, there won't be any bleed back. So there's a one-way hemostatic valve. The advantages of femoral access are numerous. It's technically very easy. It's a large vessel. You could put large devices in. There's relatively easy coronary engagement. The Judkin catheters are, in my opinion, a work of genius. They, a monkey can do this type of stuff most of the time. I mean, it just, all you have to do is advance that JL4 over the arch without any torque, without any issues, and many times it'll just go right into the coronary. So you have to keep that in mind, that these things are genius of design and very easy to gain access to the coronary arteries. Because you're standing back away from the tube, you get less radiation exposure. Our disadvantages are that there's vascular complications. Because it's a big vessel, there's a higher risk of bleeding and issues. And there's also more patient discomfort. And we usually keep patients at bed rest for a longer period of time as compared to radial access. There are special situations that you run into with femoral access that you should have a sense of how to approach. If the patient has a severe unrecognized stenosis in the femoral, you have to figure out how you're going to get by that stenosis. Some patients have an excessive amount of tortuosity. The iliofemoral system can be like the Le Mans raceway track with 180-degree turnbacks. So if you encounter that type of thing, you need to think of special equipment that you would use to allow adequate catheterization. The problem you run into there is insertion of the sheath and sheath kinking. Some patients have prior Gore-Tex graft material in this region, and you have to be, usually the best thing is to avoid that type of material. Within a few seconds, you can take what the surgeon spent hours doing and totally destroy it. So it's probably not the best idea to go through these things. Sometimes we're forced into it just because of lack of other access in a vascular path. But you should definitely be aware of prior surgical anatomy with Gore-Tex graft for vascular grafts in the lower extremity. Occasionally, we run into patients that have had so many casts that they are really scarred down, and you have to be able to contend with that idea, the difficulty of inserting that sheath into the artery. And usually we use a series of graduated size dilators to dilate up that area to get the sheath in place. And then there's the issue of, you can't hit the A. You just have spent a lot of time, multiple pokes, multiple areas, and you can't see where you're going. This is another special wire that is used when you have difficulty in crossing an area or difficulty in steering up into the central aorta. This is the 0.35-inch glide wire, and its claim to fame is that it's really steerable. It's made with these nitinol cores that are very, they maintain their shape, and you can steer around things and get into vessels, steer either in or away from certain structures using that nitinol core. It also has a polyurethane jacket. So it's infused with this heavy metal that will allow it to be, one, very slippery. So once it gets wet, you can barely hold these things. And two, the tungsten gives you excellent radial opacity. So it is a slippery, good wire for getting across areas of narrowing. Unfortunately, those same properties can make it traumatize the vessel. It can get under a plaque much more easily than the J wire. It enters small branches, and you could actually perforate those branches in certain organs. We certainly never use these wires when we're in the renal bed. You could just devastate someone by perforating through a distal renal artery. And you also have to not use them through a needle. This coating can strip off. I can't say I've never done it, but you just have to be aware that the needle will actually shave off bits of this polyurethane jacket, and that can cause embolic problems. So we have to use this through a sheath or a catheter. The special sheaths, if you run into problem with the plastic sheaths, you can get kinking. We have these special flex sheaths, which are braided metal sheaths, and they are much more flexible. And as shown in the picture there, they can, form a loop-to-loop without kinking. So you use those when you have a real tortuous iliofemoral system. These things 60 centimeters in length, so you can actually just get the whole sheath up into the central aorta, and that makes catheter exchange very easy. If the patient has a prior graft, we kind of covered a lot of this. You try to puncture away from the grafts, especially for the insertion. You give preference to sites away from the graft. And if all else fails, you can puncture the graft material, but you can expect higher complications. You'd certainly want to be ready with any dilators to help get your hole up to the right size and gently dilate that graft material. Scarring at the site, you would use progressive sized dilators. You want to give yourself a generous skin nick. And when all else fails here, stiff wires help you get into these cases. We run in with the difficult to insert sheaths. The wires can kink at the actual arterial insertion sheath site. So by using a stiff wire, the wire won't kink, it won't bend, and it will allow you to get that sheath into the artery in a coaxial fashion without kinking the wire. And if you can't hit the A, actually, this is where we used to go off and say we should use ultrasound. I would make the opinion that within the past few years, most operators that are doing femoral access are using ultrasound in almost every case. I don't know what you guys, some of the more senior attendings, Karthik or Yusuf, I think we should use ultrasound is such an easy technology and it's so available that we should probably use this in every case.
Yeah, I think it's caught on a lot in our lab too. So I think most people are using ultrasound now routinely.
Yes. The thing that the ultrasound allows you to do is you could easily see the artery. And, this is usually what you get. Your nerve is over here, vein, artery, nerve, or navel, nerve, artery, vein, empty space, lymphatic. But your artery is here. And this is, again, going from lateral to medial. And the artery can be seen pulsating. It can be seen next to the vein. If there's any atherosclerotic plaque, you could try to avoid the atherosclerotic plaque. I threw this example in here where your artery is below the bifurcation. You certainly want to stay away from the bifurcation. So you'd want to go up into an area where, provided it's not too high, you would want to try to get in the common femoral artery above any bifurcation of the SFA and profunda. So it is a very helpful technology to gain access into the artery. And I, again, as Karthik said, I think we should do this in almost every case. So I wanted to just get a baseline of what you can expect from complications. This is from the Rival trial, which was designed to look at PCI success with radial and femoral access. And they were very good in this. It was a randomized, well done, well adjudicated trial. And they were very good at looking at bleeding complications and vascular complications. And you could see that one of the tenets that came out of this, which was at least in PCI, the femoral access site for hematomas is greater. There's a 3% chance of a large hematoma as opposed to radial, where it's more like 1%. And this was statistically significant. The pseudoaneurysm needing closure was also higher. Other ischemic complications, not so much of a difference, but just serves as a baseline that in a well-done academic, carefully adjudicated trial, your femoral access hematoma rate should be in the neighborhood of 3% with modern techniques. So, is femoral access obsolete? I mean, everybody knows, oh, the radial, it's so convenient, it's so easy. It's not that easy, but it's a good way to get access. It's very reliable. And with our current techniques, it's a very low complication rate for radial access. And we know we can do PCI from that site. So why would you even bother with the femoral access? Just a shout out to my, when I made up this slide, Joe Brennan was still working here. You folks won't have the good graces to meet him. Outstanding operator, outstanding catheterization, but he retired, unfortunately. So that's what happens with all good technology, eventually goes the way of improvement. So transfemoral access, of course, it's not dead and gone. You may not be able to do radial access in certain patient groups, dialysis patients or end-stage renal disease. We want to stay away from the radial approach. There are times when we have to abandon radial access. I am not one who aspires to always get in the radial no matter what. If I see a loop or an accessory artery, I call it quits. I don't think it's worth your while to spend an hour trying to negotiate a loop. It can clearly be done, but just the question as to whether the judgment is right. My own view is when you see that type of difficult anatomy, you should just go right to the femoral access. Just another little shout out for the radial loops. The complications that I've seen with radials usually involve this idea where you can't get around an area, you keep forcing catheters, you keep trying to straighten things out, and you eventually cause some type of bleeding, and a hematoma in the forearm is a horrible thing. Those patients can be prone to compartment syndromes. So we want to try to my own view is to not persist. I would respectfully give the floor to anybody who is into the radial that says we should always negotiate these things, but that's just my opinion. Older patients can have very tortuous arm anatomy, another thing to make things very difficult. Many times it's just impossible to engage the coronaries despite multiple catheters and multiple, it's just there's some people do not have the appropriate anatomy to those short aorta patients or distorted aorta patients where you can't engage the coronaries from the radial approach. Some people don't have a radial or the pulse isn't there. And you certainly need transfemoral access when you're doing our big stuff, the TAVRs and structural procedures, Impellas, ECMO, all that equipment needs a very large artery, and we routinely go for femoral access. So certainly if you're into structural heart disease or interventional work, you're going to have to be familiar with access to the femoral. The other way to go when you're getting femoral access is to use these tiny little catheters. The 4 French sheath and the 4 French coronary catheters have caught on over the last 10 years. And you can, get a good angiogram with these things. And if you're not going to do any interventional work, it becomes a really viable and, in my opinion, very safe way to proceed with femoral access. You can do a manual hold. It's a 1.3 millimeter arteriotomy, and you have a very low expected rate of bleeding complications. So always consider using the tiny catheters when you go from the femoral. So I wanted to kind of quickly review femoral access site complications. There's a lot of things that tend to come up on boards with regard to just the tenets of what to expect. So here's a large hematoma. We have already talked about this. This is the most frequent complication of a patient that has had femoral access. You should be aware and and for interventional boards, this definitely comes up. The TIMI bleeding classification, it's become a standardized way to describe bleeding in patients, with major bleeding being an intracranial hemorrhage or a greater than 5-gram fall in hemoglobin. Minor bleeding would be hematuria or hematemesis, fall in counts that are less than the 5, and either with or without a source. And mild bleeding would be all other observed bleeding. So should be familiar. This is how most of the studies describe bleeding in the clinical setting, the TIMI bleeding classification. In the Rival trial, they defined a major bleed as fatal, 2 or more transfusions, hypotension needing pressors, need for surgical intervention, is disabling sequelae, intracranial or intraocular bleeding with loss of vision, or a greater than 5-gram fall in hemoglobin. So again, keep in mind ways to describe major bleeding. And again, it's pretty common sense, but for studies, we need to be able to kind of pigeonhole patients into appropriate groups with defining major bleeding. So this is the 30-day outcome from the Rival trial. And you can see that the large hematoma, we already went over that, about 3%. Your non-bypass major bleeding around 1%. Pseudoaneurysm about 0.5%. AV fistula 1 in 1,000. And, ischemic limbs are very rare these days. It's a handful of cases every year that we see. All major vascular complications, 3.7%. And if you add up major bleeds plus vascular complications, you get into 4.5%. So keep in mind this kind of baseline background of what we should expect in a well-done catheterization in a clinical trial. This is another study that looked at complications. I particularly wanted to throw retroperitoneal hemorrhage in there. They had a 0.5% incidence of retroperitoneal hemorrhage in their group here. Their hematoma rate was not as high as Rival. I would say maybe Rival did a better job at figuring out and adjudicating all cases, but nonetheless, 0.5%, 5 per 1,000 of patients will get retroperitoneal hemorrhage, which is our most devastating complication. This is just breaking things down. I'm not so confident with this data anymore, but it says, access site complications in the closure device area. And usually they were showing surgical complications in less than 1%. I think that's correct, but it's interesting. I throw this up here because now if you use a closure device, you kind of switch your complications. Remember, we had said that most of the complications were large hematomas and bleeding. Now it switches over to more of a higher incidence of pseudoaneurysm. And also you get this, we never see infections when you just pull a sheath and hold pressure. It's very rare to get an infection. But when you throw a foreign body in there, a stitch or a plug, you're coming up with a significant rate of infection in that site. The other thing that comes up is distal embolization of material. So you get more ischemic complications. So just keep in mind, I think the takeaway message with closures is that there's more pseudoaneurysms, higher incidence of infection, and higher incidence of ischemic complications due to foot plate embolization of material that you're trying to plug the artery with. Very important to realize. So this is, again, older stuff. This is from early 90, where the bleeding complication rates, I throw this in just to show that I think we're doing a much better job as compared to the 80s and 90s. the hematoma rates have come significantly down. And there's a number of reasons for that that we'll touch on that also tend to come up in board questions. This is, again, the same kind of thing where they're showing that the major vascular complications with time over a early 2000 period seem to decrease significantly with a steady lower decrease in complications. The other thing that is an accepted tenet of bleeding complications in the setting of catheterization or angioplasty is that these patients are high risk. If you take all bleeding patients and compare them to those that have had no bleeding, you have a higher mortality. And it's not only in hospital, but it even extends out beyond hospitalization. So very important to realize that for whatever reason, the type of patient, and it's kind of, you can figure it out easily. They tend to be sicker patients. They're patients that are obese. They're patients that are sicker from other problems. They have other coagulopathies. They have renal disease. There's all kinds of reasons that these patients bleed, and that also tends to impact their mortality. This is showing, again, the long-term continued rise over the first 6 months of a higher mortality in the patients that bleed versus those that do not bleed. So what are predisposing factors? I want to review all this stuff so you can kind of codify it in your mind to understand what things you have to worry about and what things that could what do we have control over? What can we modify to maybe reduce the bleeding complications? So there are a number of major categories. There's anatomic factors that will make you more prone to bleeding. So calcified vessels, elderly, obese, female, and patient movement all will increase the bleeding risk for the patient. The big thing that we can impact is procedural factors. We've talked about that a lot already. If you have a back wall puncture, high puncture, low puncture, multiple punctures, the larger the sheath you use, the greater the risk of bleeding. And prolonged procedures with prolonged sheath insertion all lead to higher complication rates. There's also hemodynamic factors. Patients that have an increased pulse pressure or hypertension are going to be more likely to bleed. So your aortic insufficiency patients are the kind of classic where they have these wide pulse pressures. There's hematologic factors. We see multiple patients that have been on antiplatelet medications, antithrombotic medications. They have coagulopathies. They may have had lytic agents. So all of these can increase bleeding risk. And then there's poor hemostatic technique. If you're trying to hold manual compression over an area and you're not getting over the site, you're going to have problems. And similarly, if you're putting a FemStop in place, you can many times, if that thing's not in perfect position, you can get problems with continued bleeding. So the procedural things and the hemostatic things are completely under our control. So you have to really be conscious of that. Just wanted to show that, when you're doing a PCI, the sweet spot for ACT is in the 250 to 300 range. When you get up into higher ACTs, the bleeding complications go up. So very important. And when you get lower ACTs, the occlusive problems become more evident. So very important to remember that bleeding is certainly ACT dependent. So we tend to watch our ACTs very carefully during PCI cases. I just wanted to throw this in here. These are old studies. In the late 90s, we took on the task of trying to figure out if 2B3A inhibitors were beneficial during PCI. And I'm going to stay away from that question, but I do want to talk about when you look at these trials of 2B3A inhibitors and you look at bleeding complications, it's interesting that over the 90s, these complications went down. And it was because we recognized that in EPIC, they used generally larger sheaths. So there were 8 French sheaths, and they left the sheaths in place with anticoagulation for 24 hours while they were analyzing the patient. As opposed to finally with Epistent, they put 2 and 2 together that we thought that that was a bad idea. So we moved towards using smaller sheath size and getting the sheaths out immediately after the case. So this is the data that supports what we do in current practice, which is you don't leave sheaths in place. You try to get them out as quickly as possible after a case, and you try to minimize the use of anticoagulation after the sheath is removed. So very important thing that came out of the early stent and angioplasty literature. I threw this Epistent stuff in just to show bleeding complications in the various groups. So people say, oh my God, you're going to use a 2B3A inhibitor with your stent. It's going to increase bleeding. In Epistent, that did not tend to be the case. When you compared stents only to the low-dose heparin and absicimab, the bleeding complications were lower in the group that got to 2B3A. So kind of interesting, when you use 2B3A inhibitors with ACT-guided heparin adjustment, you tend to do better than if you just give high-dose heparin and put the stent in alone. Again, an important factor to kind of gauge how you're going to use the 2B3A inhibitors. So there are certain agents that for a short period of time in the early 2000s were touted as lower bleeding complications. Bivalirudin was one of them. You should be familiar with that data. When you compared heparin and a 2B3A inhibitor to bivalirudin alone, the bleeding risk was lower in the bival group. We have gotten away from bival because of other issues. 24-hour thrombosis rates for stents were slightly higher in the bival group. And it's a very expensive group, but very expensive medicine, but it does bring up an alternative. Certainly if someone is allergic to heparin, we tend to go with bivalirudin for anticoagulation during PCI. So what can we do to prevent the complications? You avoid post-procedure heparin, you get the sheath out quickly, use a smaller sheath size, you give attention to the access site, you give attention to the technique that you use. You want to use a skin nick and express a hematoma if one develops, and you want to avoid high-dose heparin, maybe choose bivalirudin, and maybe choose the radial access site. I believe that closure devices have, in my opinion, come around as a aid to mobilization. It is not clear to me that they reduce complications, just for the reasons that we have elucidated before. They tend to supplant the cases with other complications, infectious and ischemic versus hematoma. So it might reduce hematoma rates. It might allow you to mobilize the patient quicker, but that is at a cost of increased infection and increased ischemic implications. So I want to spend some time, we have a few minutes left here. I want to talk about the most devastating complication, which is retroperitoneal hemorrhage. As we said, the incidence is hovering around 0.5% in modern trials. It is a devastating complication for femoral access. And all the things we've been talking about are mainly designed to try to minimize this frequency of RP bleeds. The risk factors, as we've talked about: high arterial puncture site, back wall puncture, female gender, low body surface area, and post-procedure anticoagulation. There's a lack of association between the sheath size, closure devices, 2B3A inhibitors, and that's because it's my opinion that RP bleeds are more technical along where the artery is stuck and your post-procedure management more than these sheath size and more mechanical things. So, you have to remember that in retrospect, it is always a obvious diagnosis. I mean, when patients have hypotension post-cath, there's this idea that, oh, maybe it's just they're hypovolemic and we'll just give them saline and everything will be fine. Or maybe it's vagal, they're having a lot of pain. I think you have to resist those urges to minimize the problems of diaphoresis and hypotension post-cath. It is so easy these days to get advanced imaging. And I think because of the consequences of delay, you should really be thinking about RP bleed very early in any patient that has hemodynamic stability or abdominal pain. Those are all very important symptoms for RP bleeds. You certainly want to quickly reverse your anticoagulation. You may consider platelet transfusions. You want to establish large bore IV lines. You want to go to early imaging. And if the patient is actively bleeding, you want to think about ways that I can stop the bleeding. And that's either vascular surgery or returning the patient to the cath lab for a PV intervention to stop the bleeding. So I wanted to kind of give you a vignette. It's a good review of a tragic case that we had at the VA. It was a carotid stent case with femoral access. The carotid stent actually went very well. Everything looked beautiful. But at the end of the procedure, the patient had transient hypotension. We didn't use any closure device. The sheath was sutured in place because he had a very high ACT. And as you could see, 366 ACT we weren't ready to get the sheath out. The procedure was concluded around 2:30. The sheath was removed after the procedure as a plan. I'll get into the details of that. And he was admitted to the MICU. So here is the procedural stick. A very marginal stick. This was before the era that we took all these pre-procedure assessment of wire and stick. So this was only found after the case that this was a high stick. You can see that the sheath kind of goes into the artery around the pelvic brim. And the other thing is that the patient has a diseased vessel. This is not a normal vessel. There's atherosclerotic plaque. And this would be a big setup for RP bleed. So at 4:30, the patient became hypotensive and in the 60s, clammy, diaphoretic, received fluid and phenylephrine. Someone interpreted things as confusion and dysarthria because he had a carotid stent. They say, oh, it's a stroke code. So they called a stroke code. The patient, as noted, was bradycardic, hypotensive, diaphoretic. The right femoral sheath was still in place at this point. There was no hemorrhage or bleeding around the sheath. And his neurologic status improved with treatment with fluid and pressors, and he returned to baseline soon after that. So everybody's relaxing. Oh, all is good. Let's just keep an eye on things. At the hematocrit was not too bad at that time. They did a head CT that was normal, and he was off pressors. He did have intermittent, they were postulating that this was, here we go, a vagal event, At around 6 p.m., they placed the PTT was down. They placed the Foley. They removed the sheath at 8 p.m. and required quite a long time for hemostasis with 40 minutes of manual compression. At that time, the abdomen was soft. There was no obvious hematoma. A femoral line in the vein was placed for fluid administration. And unfortunately, he continued to have issues. He had hypotension that required fluid boluses, and he was intubated. He received a number of kind of sets during intubation. He was given epinephrine and transfusion. He was following commands. He was on pressors. 9 p.m. Still did great. Not good blood gas, anemic. Also a question of whether he was bleeding in the thorax, but this eventually proved to be a red herring. While in the CT table, he started bleeding from both groins. He needed massive transfusions. And we'll show you, this is the CT scan. If you look, the access site is on his right, so keep chest, and we're going down. You see the liver, but there's this fluid area that's even around the liver. Look at all that fluid there surrounding the liver, and that we can trace that down. That same density starts to become much more apparent as you go down the abdomen. And this is just a massive RP bleed that is pushing the kidney over to the patient's left, and extending throughout the abdominal cavity up, causing abdominal distension. This is one of the biggest RP bleeds I've ever seen. See, again, as we get lower, just massive hemorrhage in this area, and getting all, tracks all the way down to the pelvis. We took he was not a candidate. The indwelling femoral site for access, and we did an angiogram, and you could see I'm almost done. This will be the last thing. We put a covered stent in, and that alleviated the bleeding. But unfortunately, the horse was out of the barn at this point. The supportive care was continued. He required pressors. His airway pressures were way up. His bladder pressure was way up, and he had developed a intra-abdominal compartment syndrome with high intra-abdominal pressures. General surgery did not think he would survive a removal of this blood. It's just such a huge major operation. He'd received 12 liters of normal saline, 12 units of Paxels, 5 units of platelets, 2 cryo, 13 FFP. The bladder pressure kept going up. He had this terrible compartment syndrome, and that led to just poor overall hemodynamics, and he eventually passed away. So just a vignette of what can happen in a horrible RP bleed. I think I will stop there now. If you have any questions, I'd be happy to take any questions or comments or opinions, whatever.
Thank you, Dr. Remetz. That was a great review.
All right. Take care, everybody. And I'm going to sign off here.